So to conclude and to reach to my take-home messages and to the main conclusions. What we have now, and this is a good summary that I advise you to read, we published this in the most significant journal of cardiovascular prevention. What we have seen with the use of all these trials, with the use of SGLT2 inhibitors, is that nowadays we have a complete journey. You know the concept of the cardiovascular continuum, where you start in the prevention and then you go to coronary artery disease, heart failure, and then cardiovascular death. This is coupled with the renal continuum. And what we have with all these trials that we had in 6 years, see how many of them we have here, you see that there is these effects across the cardiovascular continuum. So if you put all these trials together, independently of the phase of the cardiovascular continuum and independently of the renal continuum, you have the two sides of the same coin, which is a reduction in heart failure hospitalization and a reduction in renal endpoints. So it is time to change the paradigm and the way on how we see these drugs. This is not more anti-diabetic drugs. These are drugs that reduce cardiovascular and renal events. And that's why this has been called the statins of the 21st century, because this is much more than an anti-diabetic drug. These are drugs to reduce cardiovascular and renal events. And to conclude, this new information has changed the guidelines of the treatment of 3 diseases. First, the diabetes guidelines. If you see the diabetes guidelines nowadays, and if you see the diabetes guidelines 5 years ago, I said 5 years ago in some conferences that the guidelines will change completely after this data, and this happened in January 2022. As you can see now, the idea of using these drugs, you need to use this kind of drugs if independently of the hemoglobin A1C level, if you have a patient with high risk of cardiovascular disease, a previous cardiovascular event, heart failure, or CKD. Again, we don't need only to reduce hemoglobin A1C, we need to reduce the risk of cardiovascular and renal events. The second thing is the guidelines for the treatment of CKD. These are the international guidelines for the treatment of CKD. And as you can see here, nowadays, they are first-line therapy to the treatment of patients with CKD. And to conclude, in heart failure, the new guidelines have been published just a few months ago, the new ESC guidelines. And as you know, in these new guidelines, there are 4 pillars for the treatment of heart failure. And one of these pillars, of course, are the SGLT2 inhibitors because of what I have shown you, the reduction in heart failure hospitalization and the renal protection effects. And to finalize, because this is a module of prevention, what we have now, this idea, is that independently of the phase where you are with all these trials, you have an effect of heart failure prevention, but also an effect of heart failure treatment. And we know that these drugs are now very easy to use in patients with heart failure because this is a single dose, no need for dose adjustment, independent of diabetes status. You improve quality of life also of the patients and with few side effects. So to conclude, I like very much this sentence because we are in a new beginning. This is not the end of this story because new trials are coming up. It is not the beginning of the end. I think this is the end of a new beginning to give more benefits to our patients with cardiovascular, renal, and diabetic disease. So thank you very much for your attention. It has been a pleasure to be here, and also thank you, and it has been for the hospitality of all the people in Egypt. Thank you very much for being here with you.
Thank you, Professor Ricardo. Thank you so much for your excellent presentation. I want to ask you, do you think that inhibition of the SGLT2 only is the secret behind the effect of these drugs, or after soloist and combined inhibition of 1 and 2 can play a role in the upcoming future in this group of drugs?
This is a very interesting question. And first, going to your general question, I think that the SGLT2 inhibition is not the only answer to this. Personally, I think that we should not use the term SGLT2 inhibitors, probably we should use the term glyphosins. Why? Because they probably have benefits beyond the SGLT2 inhibition. So this is the first part. The second thing is that, as you said very well, sotagliflozin have a combined effect on the SGLT2 and the SGLT1 inhibitor. What we have seen is that the benefits are more or less the same in the two trials. So I don't think that it is because they are very similar, the effects. The number needed to treat is lower because of the population that is being treated. But going back to your first question, I think that these drugs have benefits which go beyond the SGLT2 inhibition, and probably we should think of this idea of changing the name from SGLT2 inhibitors to glyphosins because of their more general effects.
Thank you, Mr. Professor Ricardo, for this elegant presentation.
May
I wanted to thank Professor Ahmed Tamara, Professor Ahmed Bari, Professor Mahmoud Tantawi for this prestigious Congress. I have a question, please. There is a 4-pillar for treatment of heart failure: SGLT2, beta blocker, MRA, and sacubitril valsartan. Which one of them you can start in the treatment of heart failure? 4 pillars in the same time, or you prefer one of these 4 pillars in the treatment of the heart failure?
This is the $1 million question. And actually, we are conducting in our department several clinical trials to assess what should be the best sequencing of the therapy of the 4 pillars of treatment of heart failure. But going to your question and what I do in clinical practice, what I do in my clinical practice is that I try to individualize or personalize the way on how I do the sequencing to the patient that I have in front of me. For instance, if I have a patient with heart failure, with a lot of congestion, with diabetes, with acute heart failure, or with, for instance, with CKD, I usually start very early with an SGLT2 inhibitor, because in this setting and these populations, for instance, the patient with congestion, it will have a very immediate effect, as I showed you in the Kaplan-Meier curves. And this is important. For instance, you have seen in these trials, and with few side effects, that you have a very early separation of the curves when you start these drugs. So this is an early benefit. So this is the type of patients whether I start very early the SGLT2 inhibitors, given also the very good safety profile. But what I usually try to do is to try to adapt the sequencing and the therapy that I start first to the patient that I have in front of me. For instance, the blood pressure, the heart rate, also the phase of the ejection fraction, also because you have seen also this data. If the patient has an ejection fraction above 40%, nowadays you have also good evidence, and actually this week it was approved in the FDA. The FDA said that you should use an SGLT2 inhibitor in all heart failure patients independently of ejection fraction. That is the way on how the Americans, the FDA, interpreted the data. So I think, and what I do in my clinical practice, which is the most important thing, is to adapt the sequencing to the patient that I have in front of me. Sometimes I start with sacubitril and beta blocker. Sometimes I start with an SGLT2 inhibitor and sacubitril valsartan. So it depends on the patient that I have in front of me.
Thanks very much for excellent talk presentation. One of the very important topic, SB1 in diabetes and also in heart failure. As you know, also are facing the patient not only with diabetes, but with cardiovascular problem and renal problem. The other issue, we are facing some problem that the use of this group drug can cause some acute kidney injury. Especially when you can use combination of this group drug and diuretic patient. What are your opinion?
2 observations. First is, when I said this is not the end, this is the beginning of a new story. One thing that is interesting is that there, as you know, there are trials being conducted in patients without diabetes, for instance, after myocardial infarction, just to understand how we can open a new door to the use of these drugs. Regarding the issue of the acute kidney disease, I would separate in 2 parts. One thing is what we observe, which is an early decline of the EGFR when you start the drug. This is the same effect that you have when you start an ACE inhibitor or an ARB. You have an acute decline in EGFR, and then at the long term, you have an attenuation of the renal decline. This is different from having acute kidney injury, okay? And when you go to the trials, the definition of acute kidney injury, you don't have more acute kidney injury. You have a reduction in an early reduction in EGFR, but this is not associated with more acute kidney injury effects. So, and this is very clear, which is, for instance, in heart failure, you have a very early separation of the curves. The kidney benefit, you have this very early drop, and then at the long term, you have the protective effect. So this is different, and usually it takes about 12 months to see the benefit in kidney function, okay? But at the long term, you know that this is an important benefit to the patient. So I would separate the question from what is this early decline of EGFR from what is acute kidney injury. And actually, when you go to the definitions in the clinical trials of acute kidney injury, you don't see any very significant increase in acute kidney injury.
So I think to a proper evaluation of the patient before starting treatment by GFR, not only blood urea and creatinine, before starting this line of therapy to guard against dehydration and acute kidney injury, which is a major problem we are facing in our clinical practice.
This is an interesting question because we know now that these drugs have been approved from patients with an EGFR above 20 already. We go until 20. Some people are now questioning if it makes sense to measure again the renal function after starting the drug, because it probably will not change the clinical practice, because even if you see this early drop in the EGFR, we see that regarding the heart and also on the long term regarding the kidney, you will have the protection of the heart and of the kidney. For instance, in the sub-analysis, although they have a few patients, but the sub-analysis of patients with a low EGFR, you have the same benefit in terms of heart failure hospitalization, reduction in heart failure hospitalization. So some people say that probably you don't need to check again the renal function because actually it will not change significantly the way on how we treat the patients, because these patients will need the drug independently of if there is a reduction of not of the EGFR.
Any other questions from the floor?
Yes, please. Thanks for your presentation. And my question was, you have a solid contraindications for in your practice. You have a solid contraindications in prescribing SGLT2 inhibitors or not? I mean, you have certain age, octogenarians or and beyond, or you don't have this solid contraindication.
Okay.
Who is your patient? You will not prescribe IMBA or DABA from the start.
Which patients will I will not use? First, patients with if the EGFR is below 20, okay? Probably in the future we will use, but if the EGFR is below 20, usually I don't use, or at least I'll seek some consultancy with the nephrology department. Then there is a second type of patients where I think it is not a contraindication, but you should do it smartly in cooperation with diabetologists, which is the patients with type 1 diabetes, okay? Why? Because in patients with type 1 diabetes, the studies have shown that there is an increase the risk of ketoacidosis. So although you can use in these patients, because some people are using, I think we should be smart enough to do this in cooperation with our colleagues from the diabetes field. So this is the patients where I have some precautions. Regarding the age, I don't see any, there is no interaction regarding age. And always remember that patients with a higher age have more events, and therefore the absolute risk reduction usually is more. So age is not a contraindication for the use of these agents, although in the beginning, some suggested that they could not be safe in patients with a higher age, but this is not true nowadays, and I use in patients independently of age.
Okay, thanks very much, all the speaker. دكتور احمد اتفضل.
We would like to thank you very much, Dr. Ricardo, but I have a question, but it's more than enough now. You can take a rest and we will